So advancing a little bit more with invasiveness, we're going to talk about the role of surgery, surgical management in the early stages. And this will be presented by Dr. Mario Castro Medina. Mario is Assistant Professor in Cardiothoracic Surgery here at Children's Hospital Pittsburgh. Mario.
Thank you. Well, I would like to say thank you for the committee for the invitation for this presentation. I don't have I don't have any conflict of interest. I just want to tell you guys that I was born and raised in Chihuahua, for those you guys don't know. So the objectives of my talk is present the Children's Hospital of Pittsburgh experience and the different strategies for the Norwood procedure. The reality is that the Norwood procedure is basically a few parts of the surgery is create a good flow to the pulmonary arteries, that is the BT shunt or the Sano shunt, is the aortic arch reconstruction, and basically do the DKS. So reality is not that difficult to do a Norwood procedure if you divide in your mind in basically these 3 steps. So first we need to create a good BT shunt, make sure we create a good aortic arch, and the creation of the flow to the pulmonary arteries. So on the DKS, it's very important to have in mind that we don't have any torsion of the coronary arteries. And the 3 different approach that we can do is the standard Norwood, that is with the BT shunt, and the Sano, with the other one is with the Sano, and the third one is the hybrid procedure that in our institution is basically for the high-risk population, as Dr. Kreitzer already mentioned. When you have a Norwood procedure, in your mind always needs to be that if you're gonna cannulate the PDA, if you're gonna do selective cerebral perfusion, that in the last probably 5 years or 7 years in our program, we're doing the selective cerebral perfusion. It's still using hypothermia. We're still using the homograft and the BT shunt between 3.5 millimeters, 4 millimeters. And the Sano, usually we do the dunk technique. In our program, the Sano technique is basically for the patients who have any aortic abnormalities of the aortic arch that they're not a good candidates for the Norwood procedure, or if we're thinking that it's a high-risk patient in the unit, like a low birth weight, that it's between the 2.5 to 3 kilos, not less than 2.5 kilos, that we might consider use a BT shunt. Also, maybe like Dr. Sanchez de Toledo say, who's in the ICU. So in the consideration on the Norwood procedure, always have in mind that I think that game changer for all the new surgeons is using the selective cerebral perfusion, because that give you time and you don't need to run for the circulatory arrest. So that's give us an advantage at the time to planning the procedure. The DKS is the most important part, so that at that moment we don't twist the coronaries, because if we have any coronary problem, at this point there's no turning back point on this patient. So that needs to be very important in the surgeon's mind at the time doing the DKS. Also, all the time during the bypass, you need to keep an eye on the heart, make sure there's no any electrocardiogram change, so that we don't have any ischemia. And for the reconstruction of the aortic arch, we usually use the D-cell homograph. We used to use sometimes bovine pericardium, and basically is to enlarge all the way to the descending aorta to create a new aorta all the way down. So those are the main steps for doing a Norwood procedure. Now on the dunking technique, this is usually a Gore-Tex ring that usually, as the technique say, we dunking in the right ventricle. So the rings are protecting the graft to be stenotic at the time of the contraction of the ventricle. So those are the different techniques. So in our experience, so I'm gonna show basically from 2004 to 2020, I reviewed this data for our experience as a Children's Hospital of Pittsburgh, and basically to see what is the transplant-free survival at 1 year, the 30-day mortality, the discharge survival, the interstage mortality, and the completion of the palliation and the long-term survival among these survivors. And you will see that this is the characteristics of the patients. We divide between 2004 to 2009, 2010 to 2014, and 2015 to 2020. And then you can see the difference between these patients. You can see that in the late years, we were taking care more of the patients who has any syndromic disorders or they have any chromosomal abnormalities. Also, you can see here the weight of the patients in some of these variables. And these are the other characteristics about the patients. What is the diameter of the ascending aorta? What are the C-scores on the pulmonary arteries? That basically in our program, there's no, any size of the aorta, there's not a contraindication for doing Norwood, but we look this data to present. Also, you can notice that it changed, that these high-risk Norwoods, that they have ventricular dysfunction or valve insufficiency in the late years. Basically, we did not do all those Norwoods because probably we did for the hybrid procedures. This is where the anatomic characteristics of these patients is a total of 140 patients, and you can see that the most common were aortic atresia and mitral atresia. You can see on 29%, Chon complex was 13%, and the other variants were very, you can see here in these slides, like the one in the left ventricle is only 4.3%, and this is based on the different years that we divide these patients. You can argue that the hybrid, in the last years we did more hybrids, and you can see that these hybrids after that paper that Dr. Kreitzer and Dr. Morel write it, that's when they describe the high-risk patients for our Norwoods, and basically we're the ones who have dysfunction, we're the low birth weight, and those were the ones who consider to do for a hybrid procedure. You can see in this data that basically we're not a very strong program using the Sano shunt, and I know that everybody will argue that the single ventricle trial will do a lot of Sanos because they show better survival, but in our data, in our hands, we were better with the BT shunt. And you can see that in the last years, from 2015 to 2020, our times of bypass time are longer. And what that means is because we have a group of young surgeons that are performing the operation. And in the last 5 years, we're changing from using selective cerebral perfusion. So you can also see it on this in the cross-clamp time and the cardiopulmonary bypass time in this data. Now, the outcomes of after the Norwood, you can see it how they changed through the years. And the ECMO on Norwood, we probably in the last 10 years, we're more aggressive using ECMO in this to rescue these patients. It's a decision that we don't delay. And if there's any doubt or there's any consideration for any residual lesion, we just go on ECMO. And we're not afraid to cut these patients or looking for any residual complications. Now you can see that interstage mortalities, these are our numbers, 4.9%. And our they went to a Glenn procedure, 92%. So those are basically our numbers. Interstage mortality, 4.9%. So those are in this different era. Now you can argue that from 2004 to 2009, the interstage mortality was 2%, but to 2015 to 2020, we have more kids with some genetic disorders. The other thing we can argue that in the last years, so we start doing some of these patients with the intact atrial septum. And from shunt revision, this is we did a chart on these. The patients that need any shunt reintervention can be catheter-based procedure or surgical procedure. This is where our numbers. I'm not gonna go into the different situations, but I just wanna show that we're not afraid in our program to cut the patients and solve the problem. because in our mind is move the patient forward so we can rescue this patient and send them home. Now, the overall long-term survival, you can see at 10 years, we have 70% of survival in our group of patients that had a Norwood. You can see it as at 10 years. Now, the transplant-free survival at 1 year after the Norwood, you can see that in the last, from 2015 to 2020, we have a survival of 90, free of survival at 1 year, 92%. So this is our numbers that we look at in this cohort of the study. Again, in the 1 year transplant-free survival among the discharge survivors, you can see 94%, and it's higher at the 2015 to 2020. So our conclusions is basically, as Dr. Sanchez mentioned, and Dr. Kreutzer, you need to establish your team approach. For my always remind to use selective cerebral perfusion. Don't be afraid to reintervene or cut this patient to find chump problems. And one of my recommendations will always learn how to manage ECMO in the first stage. And that will be my talk. And thank you so much.